Yeah, presenters view.
That's good. You'll see the next slide then. That's easier. So we're going to talk about treating sleep apnea. And I have been involved with the Inspire for a long period of time. It's winding down, but I was involved in some of the research in the original trials. I have research in this stuff. So metrics is the negative pressure around the neck. And 7 Dreamers is something called a nastent, which we'll see. And I sent you that ventilatory control system, and to make the point that the lungs don't breathe unless they're forced to. And so your brain has to sort of activate your nerves that activate your muscles that activate the muscles in the upper airway to be able to open the airway to get air into your lungs, and then you breathe with your diaphragm and your intercostal muscles, and then oxygen uptake occurs. The cardiovascular system delivers it to the tissue as well as to the sensors in the carotid body and the brainstem that adjust then your breathing. So we want to talk about risk factors. We want to compare the risk factors that to physiologic pathways, looking for causes. We talked a little bit about that in your review, Zach. So some of this will be a review of what Zach's paper was all about. Right. Importance of critical closing pressure and appreciate other targets. Okay. Apnea types. Central apneas in 1980s, we called them non-obstructive apneas, mainly because central apneas tend to imply that it's all a brain function. And as you'll see, I think it's all brain anyway. Obstructive apneas are where the upper airway closes, and mixed apneas is a combination of a non-obstructive and an obstructive apnea. And then we have different subtypes. Flow limited breaths, hypopneas of all types, respiratory effort related arousals, RERAs, without hypoxemia, and then all sorts of various things that people look at. Cheyne-Stokes respiration is at a longer time frame. So remember, these are just classifications. This is botany. This is, that's a maple tree, that's an oak tree, that's a hickory, and you go, oh gee, but they're all trees. Yes, they're all trees. They're all trees. So I want you to look at this videotape, and I want you to hold your breath as long as this person does. Notice how this person sounds, how the chest wall moves, and how would you ask a question of this problem. So let's make sure it starts. There we go. So what do you think, guys? Is this a non-obstructive, obstructive, or mixed?
Looks obstructive.
That's very special.
So you sit there and you got all these things going on, right?
Doesn't look like it's compatible with life.
It's all right. He got up, did stuff. I treated him with CPAP. He felt a lot better. So what are the animals that have obstructive apneas? The ones elephant seals, and they actually have more elephant seals, right? So evolutionarily, they're okay. And then the other group is bulldogs. So let's go through this a little bit more. Let's see what we got here. Here it is. Okay, so he's breaking from an apnea right now. And you can see that he does all sorts of different things. He lifts his chin up, he does all sorts of other things. And then he has 1, 2, and the third breath is obstructed. And his abdomen is going out and his rib cage is going in. See, the diaphragm's contracting, pushing in. 1 breath, 2 breaths, obstructed. Stop breathing for a pause for a little bit. And he starts up again. These efforts get bigger and bigger as his respiratory control and his sensations and all that kick in. If you look closely, you can see his alanase are activated. 1, 2. And he stops breathing for about 3, 4, 5 seconds. So this is probably what they were noticing in 1961, 62, Kulo and Dahl. They were neurologists and an ENT guy, and they looked at this person. They had corpulmonale. Wasn't this person, but they looked at this person, had some daytime sleepiness, had what they thought was a Pickwickian syndrome, and they said, the only way to treat this guy is half. How do you think they said the only way to treat him?
Surgery.
Well, what'd they do?
They were pretty tonsil happy back then. Or was that prior to?
What'd they do?
I was thinking tonsillectomy, but also maybe a trach.
Yeah, they trached him. And what happened? Pulmonary hypertension went away, sleepiness went away, breathing went away. The guy said, why the hell do I need this trach? I feel great. And they wrote 3 papers on it, all the same page, one in German, one in English, one in French. And they described this as some sort of form. And really it was the Europeans, the Kulo and Dahl, and then there was a group in Italy, as well as a group in Germany and a group in France. And it was really the Europeans that really identified this. And then it quickly came over the United States, and people reported doing trachs and getting all sorts of various things for this condition. Let me, there we are. Okay, so the clinical recognition that we do, all the things we just talked about, snoring, tired, observed apneas, hypertension, BMI, age, neck circumference, and gender. Those are all either anatomy, symptoms, consequences, or demographics, and these are all done during wakefulness. And we always get this as well. That is, we find all these things and we do this, but really recurrent sleep apnea, it's associated with it. It's not causal. So obstructive sleep apnea, here's an example of one. And this has EEG on the top 2 lines, EMG underneath the chin, submental, EKG, oxygen saturation, flow, tidal volume, esophageal pressure, which is a measure of intrathoracic pressure, which is a measure of the effort to breathe by your rib cage abdominal muscles, and then respiration itself. So what you see in the middle here is an apnea, which is characterized by a lack of flow at the nose and mouth, but there is continuing respiratory efforts with the esophageal pressure swings. So here's an example of early on where esophageal pressure swing is this much. And then you have one later on in which it's this much, and then it gets bigger, and then they break from the apneas. Now, that's the apnea, the end of the previous one. And you can imagine that's what's happening there. And then they wake up and the arousal, but it's also not only arousal in the EEG, it's a change in the EMG activity. So the same muscles that might produce an apnea don't really take you out of an apnea. And what you'll notice is at the onset of this apnea, there's a reduction in submental phasic EMG activity. There's a reduction in esophageal pressure. If the airway is closed and it's the same esophageal pressure, that means that there's a higher resistance. And here's one in which it's completely obstructed and it gets less and less and less, very little, and then goes up again. So this first part of an obstructive apnea is the second part of it is the CO2 and hypoxic sensors kicking in and giving you bigger efforts and giving you that snort at the end. And the first part, though, is this time in which respiratory drive is low. And in this particular guy, we just saw he had one obstructed breath and then had a pause of about 2 or 3 cycles and then started up again with obstruction. But a mixed apnea is a combination of central and obstructive events, but those are just botany. Really what's happening is there's a reduction in drive and something happens to close the airway. Now, the example you just had, it was not somebody taking a noose around their neck while they were asleep and sort of blocking it off abruptly, although it sounded that way. It was really much more of a sort of a 1 breath, 2 breaths, 3 breaths, and those breaths had longer expiration, longer inspiration, so they were actually going into respiratory drive. So the pathways that we talked about last week is you have this anatomy, collapsibility, and if you don't collapse, you don't have an obstructive apnea. But then you have this gain, poor muscle recruitment, and sleep-wake transitions. And this goes back a long period of time, even before the original Eunice et al. 2007 to when I was here in 1980s. But we really never had it as this crisp an idea. And there are kind of other people have kind of taken this and maybe teased apart various parts of it, but these are the 4 major pathways. So if we sit there and you say, what's the closing pressure? What's the idea of a critical closing pressure? Now, Faisal can tell you why it's important in chronic obstructive lung disease and breathing out, right? That's the equal pressure point on expiration. Right, Faisal?
Correct.
That's flow limitation. That's why in the middle of an expiratory flow curve, you hit your critical flow and you can't get bigger or better. But in this case, you just reverse it. And the idea of negative peak crit keeps your airway open. It pulls it open. So think of it, that's why it's called negative. And positive means that it closes when there is no particular force on it to counteract it. So the mechanical properties of the upper airway, going from the posterior nasopharynx down to about the epiglottis are the important feature. Now, how do you measure this? Well, if this is closed and this is open, you can pressurize this snout and you can pull down this pressure and the maximal flow will decrease. Now, there are experts in flow and I can go on beyond that. This is very simplified idea of a Starling resistor. But let's look at point D is when at 8.5 centimeters of water, your flow looks really good. 8.5. At a pressure at the nose of 1, you're collapsed. And as you increase the pressure up there in the upstream pressure, you can open this airway. So really it is that the flow and the ability to transmit flow is dependent upon the upstream pressure. It's not how hard you suck. It's what this airway does to close it. So you could try as hard as you can, and you will not, if you're down here, you will try as hard as you can't open it up. Now you might say, well, people snore, but that just means the property of the upper airway, it doesn't collapse enough. So here's this flow limitation. It starts out on a regular flow like it does here, but then it chops off and you can't get enough flow. So CPAP counteracts this, and you can see this peak crit can be calculated there. And at the end of the fellowship last year, and what we'll start doing now is every time you see a CPAP titration in the PSG lab, you can construct these pressure flow curves, and you can find out what the peak crit is. You can estimate the peak crit of this particular person. So peak crit is important in everyone with obstructive sleep apnea. This green is you don't have it, red is you always have it, and this in between part of about -5 to maybe -2. Usually people go to about +1. You have a vulnerable anatomy. It could go either way. What that means is you could obstruct your airway or you could not obstruct your airway. So it depends on this. But what happens is you see once you get over this line here, this is the number of apneas from 0 to 120. You could have a closing pressure of 0 and you could have an apnea-hypopnea index of 20, or you could have a closing pressure of 0 and have an apnea-hypopnea index of 120. So the severity of the apnea is not dependent on the closing pressure itself. So that's why these other pathways are important. And what are these other pathways? Or it could be my wife coming home, could be. Let's see what I have to worry about. Nothing right now. Okay. So if I take a person with obstructive sleep apnea, and let me look here for a second. I'm going to pause for a second. And what happens here is you have recurrent. What kind of apneas are they? And what do you see? Yeah, my wife just got home. So these are what? These are central apneas. And they have 1, 2, 3, 4, 5 breaths in between. And they have a certain length to them. And they're non-obstructive apneas. So you give them 3 centimeters of water and you have recurrent central apnea. So what's the peak crit? Somewhere less than 3, right? 2 or 1. And you'll see people that respond to obstructive apneas with a very small amount of CPAP. So the loop gain is what people get all crazy about. This, I don't like to call it loop gain, I just call it gain. And it's the idea that this gain explains both obstructive and central apneas, that if equal, you have non-obstructive. If everything falls below the threshold and the airway is normal, you'll have a central apnea. If, though, the drive and the abnormal airway is there in the upper airway, you'll get drive that still occurs in the chest wall muscles, but it'll go below this threshold for carrying air in the upper airway. Is that clear to people? Is that, you guys got to go time out or tell me if I'm going too fast. I mean, that's the whole feature there.
Can you explain that one more time?
So what you have is you have 2 things. One's the diaphragm and one's the upper airway. And these are really the mechanical properties. So the diaphragm's pumping away and the upper airway's pumping away. And if they go below a threshold where they no longer pump and the airway the airway is open and they no longer pump, they'll have central apnea. If they get to a point where the diaphragm is pumping, but it's gone below this threshold for the upper airway, your upper airway will close and your diaphragm will still continue to pump. And what you see here is this reduction that occurs and then comes back up, just what you saw on the EMG activity. Okay,
My second paper had this type of a graph in it,
yeah.
that little one.
This was Cherniak, who I first came here. He was here. He was the head of pulmonary and then became dean. So loop gain is higher in OSA. This gain is higher. And you can actually treat it. And so it comes out to be a conceptually, you have this P crit and you have this gain, this loop gain idea. And you have this area here where you may or may not have obstructive apneas. But if you have a high loop gain, you'll have central apneas. And if your peak, so your P crit gets more and more harder to close, you'll have central apneas. It's stable upper airway. And here you'll have an unstable upper airway. As soon as you get up to a P crit of 3, 4, 5, it really kind of doesn't matter to some extent, because your airway will always close when you have a reduction in drive. So these two things interact. And there are therapy implications, and that you could decrease this gain and go from an unstable upper airway to a stable upper airway. But most of the time, most of the time we use CPAP, or we do surgery, or we do something else, and we try to reduce that P crit so they get into a more stable position.
What is the unit of measure for loop gain?
What's that?
How is loop gain measured? Like these units up the side, is that a time measurement?
Well, it's an arbitrary unit, and so what it is a tendency to return to a set point. I had sent a PDF file on central apneas that sort of went through it in some detail. So what it really says is the proportion of your response to the initial disturbance. So if your initial disturbance is, say, a reduction in drive of, I don't know, say of 0.5, and your response to that is 0.2, that'll be really a damped response. And so that's a 0.2 over, over a 0.5. But if your response to that is 0.5, you'll be closer to 1. So as you're closer to 1, you have this higher gain, because the disturbance will then set up your tendency to come back. So that's that same thing I did with a pencil or with that Q-tip. So the more bouncy that is, the higher the gain.
So I guess also part of my question would be like, how is it calculated? I mean, is it
The Wellman et al. Originally can do it with a dial down technique, in which they take a person, put them on CPAP. They put that CPAP down to a level that is almost where they will close. They hold it there for about a minute or so, and then they release it and see what the overshoot is. That's how you measure it. So it's really an arbitrary unit.
So it's a ratio of the original pressure over the overshoot?
No, it's a ratio of the original disturbance. It's the overshoot over where you expect them to be in their breathing.
Okay, that makes more sense.
But it's an engineering. It comes from it. If you're interested in it, they have lots of articles on it. I don't know the math, but I kind of follow what they do and how they do it. It's not something you can do easily in the laboratory. It is something you do in the laboratory, but you generally need a bunch of people and knowing what they're doing. And you could do it if you're in the sleep lab and you've got a CPAP titration going on. You just have this person, their airway open, and you drop it down, and boy, you can keep it there, right? They'll obstruct. I can take you and put negative pressure at your nose and obstruct you. And I can measure your loop gain that way, right? Zach, how about that?
That
When
makes sense. I mean, when people are laughing, they'll snort. And so
Yep.
that's the
Yep.
laughing going against the
Laughing, they'll snort. That's a good one. I hadn't heard that one. That's a good
because they're sucking in so quickly, they
right.
collapse, right?
Right. But you don't really collapse sucking in quickly. You collapse because it's sort of like the sides of a ditch, right? You take the stability, you take those plywood at the sides of a ditch, you take them off, and those guys get down there and try to fix your house, and those ditches will start to slide in toward them. Okay. So optimal OSA treatment will maintain upper airway patency during sleep, restore sleep continuity, retain adequate gas exchange, improve quality of life, sleepiness, neurocognitive function, lower diurnal pressure, and decrease all-cause mortality. And so that's what I'm trying to define here, what a healthy situation is, and how do you want to get to it? So what is it and what does it do? So you got this stuff. Anatomy is the biggest thing. So the tracheostomy, what does it do? Bypasses the problem. And by bypassing the problem, then you have, we'll go pretty quickly through these things because, it's a cure. Residual central apneas usually resolve over time. No psychosocial problems. So this is the nastent. I've got them around there. I'll show them to you. They're little soft little silicone tubes you can place in your nose at night. Gets you past your nasopharynx and keeps it open. It's sold in Japan and in Europe. And they're trying to see whether or not they can get FDA approval here in the United States. It's a cute little idea. It has a little clip to prevent it from slipping down your nose. But it does a good job there. Nasal CPAP does an airway splint. Positive pressure counteracts this negative pressure. It doesn't care where the airway closes. It just opens it. Also increases functional residual capacity, which increases your oxygen stores and decreases your loop gain. But its major effect is because of its an airway splint. And this is an example from one of the first examples of it, 1981, but it was described first in 1979. And this is all night with 6 hours without any sleep CPAP and 6 hours with CPAP put on right at the beginning. You see, it just stops it in its tracks. This is remarkable. The airway gets bigger, but it doesn't get bigger as a tube. It gets bigger in funny, different ways. This is wakefulness, though. We're going to try to do some things during sleep. And this is a patient asleep. This is something I did early in 1983. This is on CPAP. We drop the pressure, nasal pressure towards 0. This is abdominal motion. Motion continues. There's no airflow. So this is obstructive apneas. This is genioglossil EMG. It doesn't immediately respond. And then it does. The person wakes up pretty quickly. We up the pressure right back to where it was, and they go right back. It's kind of cute, isn't it? So that's that gain of muscle activity that they talk about. You can test that as well. So it's a small collapsible airway. Muscle response is not relevant in CPAP. Doesn't care. Acceptance rate is 50% about, maybe 60% now with better stuff. So oral appliances, you got tons of them, and their advancement is to decrease it by about -4 to about -10. Some of them are better than others. Depends on the laxity of your jaw. But if you sit there and you say, okay, if I get to a -3, I'm unlikely to have obstructive apneas. Then if your CPAP is, if you get 6 out of it, you can treat that person. So that person that responded to 3 centimeters of CPAP might respond better to an oral appliance. But it's the purpose of the oral appliance. It may or may not increase muscle activity. There's one study that suggests that it increases upper airway muscle activity because it changes the proprioception of the upper airway. And incrementally, you can incrementally do it. So the control, and then you put it, oral appliance gets forward 2 millimeters, 4 millimeters, 6 millimeters. And this is oxygen saturation. Obese, less effective than non-obese, probably because of peak crit. But it's not well predicted by AHI. Now you know why, because the peak crit doesn't necessarily correlate terribly well with the apnea-hypopnea index. So, surgery. Surgery wants to do size and compliance, right? There's only one RCT showing effectiveness of uveopalatal pharyngoplasty, but it's really not as predictable as one would want. There are many surgical approaches. There are no peak crit measures. They're just starting to do peak crit measures before and after surgery. It's pathetic. And it's pathetic even in our place, because we could have done that. I mean, I'm not saying that other people are pathetic. I'm saying the field is pathetic. Not as predictable or durable or as generalizable as one would want. You want to have it work for 2 years? Well, it may not. It may work for 6 months. This is the randomized control trial. On the left is the intervention with the uveopalatal pharyngoplasty, and 4 people either didn't change much or got worse. But there were people in the control group that went from 40 down to 10. How about that? So it's a watch. It was a watchful waiting was the control. Mandibular or maxillomandibular advancement. Its success rates in selected people, very carefully selected. And still no measures. I've heard that people are doing it this year. Next year at the sleep meetings, there'll be 3 or 4 groups that are doing peak crit. We don't do those very often. And the problem is that the people that do maxillary mandibular advancement think that the sleep docs don't want to do it, and they have the most effective surgery, but they really don't want to measure peak crit, and they don't want to do sleep studies after the procedure, because oftentimes they do these things for cosmetic reasons. And sometimes when they do it for cosmetic reasons, they never measure, not sometimes, almost always, 80% of the time, it's only the parents of kids that come and say, does my kid have sleep apnea? They're going to do this operation. I've heard that maybe they have sleep apnea. It could be fixed. And I said, you mean they're not measuring it? And they go, no, they don't have to, because they're going to fix it. And you go, oh, you'd like to know what they did beforehand. So there are all sorts of things you'll hear about. Theravent or valves that prevent or restrict the airflow on the way out. So a bigger airway at end expiration makes you a bigger airway in inspiration. And there's some new things you'll hear about at the VA called Bongo, Optipillows, a couple other things that we're trying to look at, especially now that they have this CPAP recall. They're funny little things. We got some examples. Other thingies. There was a Winx. It's no longer on the market. It sucks your tongue forward, but it also sucks the saliva out all night long. And this other thing, the CNAP, which we're going to be going into clinical trials the end of the year. It's negative pressure around the neck. CNAP in the trials that age 55, BMI about 35, and it's negative pressure of 29 centimeters of water outside at wait a second. Here, Charlie. Come here, Charlie. Come here. Here. Charlie. Here. So you can see that a lot of people responded well. We'll see what happens in the clinical trials. This 18 or 15 people. Anatomy, we've shown that it makes the airway, posterior airway bigger. It pulls forward the anterior part of the throat. So obesity loads the system. The higher your obesity, the higher your weight, the bigger your P crit. Okay, hold, stay. Okay, weight loss for OSA, P crit is reduced. That's how it works. It also changes a little bit the lung size. So lung size is bigger, so loop gain is a little bit bigger. Maybe it works on muscles, work better, but no one's really shown that. Neuromuscular therapy. So if the EMG activity is reduced, this is genioglossal EMG activity, protrusive muscle of the tongue. It goes down during an apnea at the beginning and then comes back up as you recover. There's timing as well as EMG activity, so it's coordination. Neuromuscular therapy could pull you into a normal position. And if you look at gain in upper airway instability, the ventilatory motor activity, when it goes down, upper airway resistance goes up. So that's how you can have these RERAs, you can have these hypopneas, you can have these episodes where there's high upper airway obstruction, and don't have to have particular apneas. So what do? So this P crit curve, the one I showed you is called passive. That is no EMG activity. But if the EMG activity is there, it moves it. And there's a difference here. And the guy that's coming, Sushil Patil, is the first author here in 2007 of showing these different different P crits depending upon the activation of muscles. Well, either all muscles or some muscles. And that really, this is what you want to do. You want to move this curve to the left. That's a little oversimplification, but that's what you want to do. So I showed you genioglossus, and everybody focused on genioglossus. I focused on genioglossus. 1978, I measured the genioglossus. And so this Inspire therapy is all based upon the predicate that the genioglossus is important. Now, we don't know if that's true or not, but first proof of principle we showed here in 1993. We put in fine wires in the hypoglossal. In 2014, they improved Inspire. I was not involved in any of those FDA trials. I just showed the feasibility in people in 1993. As I was funded by Medtronics at that time, but I didn't know really what they wanted to do. I thought it was neat. I was doing a lot of animal work on muscle stimulation of all sorts of muscles. And we knew that the genioglossus was not the only muscle that opened the airway. So you place it around, the surgeon places around the nerve. You'll see a bunch of these around. Upper airway stimulation works. You turn it on and you stop these apneas. And there's little things in here that are fun to see. These are 4 consecutive obstructive apneas. You turn this thing on, the airway reopens, and then there's a little interesting little kind of, see this little drop here in breathing, and then it goes up and comes down, and it evens out. There's a gain response to that too. So does it work? Let's see if I got these working. Yeah, here you go. So that's the palate. The palate opens up, and the back of the tongue opens up. Right, so the left is not anything, and on the right is the therapy that they have at home. But it's big. It's big. You have to open it up this much. I mean, is that true? What is that? So that's what we're interested in. So there are other myotherapeutics, playing a musical instrument. So that's the other thing that Denise DeWalt is interested in. But these are the background. Playing the oboe and the bassoon, reduce risk of OSA by a pretest probability. Didgeridoo, improve sleepiness and the apnea-hypopnea index. What is it? It's training. It's been 1908 was the first description, but it's still on there. You can take a kid with a retrognathia and you can train them so that their chin moves forward. Pretty cool. You can train to get rid of disordered habits, disordered things that happen. That's the Rogers exercises in 1918 that were all around the country, all around the country. There are some speech therapists. There are some voice teachers that think they can treat OSA. You'll run into people who have done that. There's a franchise that's $300. You pay them $300. This is a puppy waste. And then there are a series of exercises that were done and published in the Blue Journal. And you can see that those people, the control group didn't change much, but the therapy group decreased. Now these exercises, they had a significant decrease in AHI from 22 to 13. Chewing up our pillows. Okay. But if you want an example of what you did, here you go. These are the exercises. You brush your tongue. You do 8 different exercises. There you go. See, and you do that for about 10, 12, 15 minutes every day, 7 days a week for 10 weeks. Not too exciting. It's all right. Tongue up to the top of your, and it seems to work. So I think those are interesting. Are these formal regimens actually necessary? There's some expiratory muscle training, other things that need a more rigorous approach. The problem with all this is that you can try something and it works, but you don't know why. You don't know what muscles are important, and you don't really have an idea of how long you need to do it. And you have to do it based upon the principles of speech therapy or of voice lessons, and how to image the airway. And Faisal, that's why Denise is looking for ultrasound measures to be able to look at the lateral wall and see if she can define what muscles are doing to the lateral, to the walls of the upper airway particularly in the palate. Also, there's the idea is that that your ability to use your upper airway and to have it dysfunctional may be related to early life, in particular breastfeeding, bottle feeding type of food, etc. So the other part is insights, basic science on medicines. So the hypoglossal nerve itself has different gene expressions, and you can pick cannabinoid receptors because tramadol reverses central apneas. Muscarinic tone in REM decreases in genioglosal EMG. Adrenergic withdrawal and non-REM sleep depresses genioglosal EMG activity. So you're gonna in your lifetime, you're gonna have medicines that treat obstructive sleep apnea. I don't know how good they'll be or what they'll do or how they're gonna do it, but this is where it comes from. This is the basic science. And here's one example early on. It's a hot topic. There's a new company, all sorts of things about this. So the druggable pathways for recurrent OSA for loop gain is oxygen, acetazolamide, buspirone. For sleep wake mechanisms, it's trazodone and benzos. poor muscle response. We'll talk about this in a second, but tramadol and then these other meds. So atomoxetine increases adrenergic tone. It's a reuptake, norepinephrine reuptake inhibitor used for ADHD. It's off-label use, 2017. And oxybutyrin decreases muscarinic tone in REM. And it's an anticholinergic used in urinary bladder difficulty. So both of these are off patent, which drives drug companies crazy. But they use these together, and here you go. You got a total AHI off on placebo of about somewhere around 32 in the average. Both together it goes down to somewhere between 2 and 12, but each alone doesn't do it. So I'm going to leave you here at this time just saying that, you know, people have not measured P-crit. They've not measured these sorts of things. I don't think these medicines work only on the hypoglossal motor nucleus. I think they work on neurotransmitters that activate other parts of the upper airway. And the holistic thing that we look at is what muscles are working where to keep an airway open enough so you can breathe during sleep. Well, this is, I guess, the interesting thing is that they showed with these two drugs that the recruitment of the genia glossus was greater during an apnea. So, okay, we're going to get over this again, but this is a sleep-related disorder. It's caused by an abnormal anatomy. It's a reduced muscle activation. And to make a lot of apneas, you need a gain of sensitivity. And the current therapy, though, is anatomy and muscle activation through stimulation. Aspirational is drug therapy and lubricant. I'm sorry for the interruptions by the dogs. And I'll send you PDF files of these things because the other ones are